Hello, namaste students. So till now we have discussed in cardiovascular system examination, the general physical examination, pulse, blood pressure, jugular venous pulse, JVP measurement. Okay. So today we will discuss about the inspection, palpation, percussion and auscultation of cardiovascular system examination. Okay. So what are the things you see in the inspection of cardiovascular system examination? Okay. First is the apical impulse, whether it is visible or not you have to see. How do you look for apical impulse visibility? So you have to look tangentially like this, okay, that is one method for the apical impulse, and the other is you can go from the foot end of the patient and you can observe the apical impulse from the foot end. After seeing the apical impulse, you have to look for any precordial bulge is there. Again, precordial bulge you will look by looking tangentially like this, bending like this, okay. Suppose if there is any precordial bulge, that indicates right ventricular hypertrophy before the onset of puberty. For example, if the patient has a atrial septal defect, there will be a right ventricular hypertrophy and before the onset of puberty, so if it is there, so they will develop the precordial bulge. Then what are the other things you see in inspection of cardiovascular system examination? Carotid pulsations. A prominent carotid pulsation is seen in aortic regurgitation, high output states, aortic aneurysm and coarctation of the aorta. So after carotid pulsations, any suprasternal pulsation is there, you will just see. Suprasternal pulsations, if it is there, that indicates again aortic aneurysm, coarctation of the aorta, thyrotoxicosis, aortic regurgitation. Then you have to look any pulsation in the aortic area. So you have to look for aortic pulsations. Where is the aortic pulsations? You look right second intercostal space, you look for the aortic pulsations. If aortic pulsations is there, that indicates again aortic regurgitation, aortic dilatation and coarctation of the aorta. Then any visible pulsation is there in pulmonary area. Pulmonary area is left second intercostal space, you will look there. So any visible pulsations in the left second intercostal space indicates pulmonary artery dilatation or pulmonary hypertension. Then any left parasternal pulsation is visible, you will see it. Left parasternal pulsations they will be there if there is a right ventricular hypertrophy or left atrial enlargement. Then you look for any visible pulsations in epigastric region. There are three pulsations in epigastric region. One is left lobe of liver, right ventricular hypertrophy, aortic pulsations, in aneurysm of aorta, aortic pulsations you may see. Then on the back, in the interscapular and infrascapular, if there are any visible pulsations, that can be a clue, a Sussman sign, coarctation of aorta. Then any kyphosis, scoliosis is there, or any scars and sinuses is there, you will look in the inspection. So dear students, I will repeat, what are the things you look in inspection? Apical impulse, tangentially or from the foot end. Any precordial bulge, again you look tangentially. Carotid pulsations, aortic pulsations and pulmonary artery pulsations, which you aortic and carotid you get in AR, coarctation of aorta, hyperdynamic states. Pulmonary pulsations in pulmonary area you get in pulmonary hypertension and pulmonary artery dilatation. Or any pulsations in the left parasternal region, which you get due to right ventricular hypertrophy or left atrial enlargement. Then any pulsation in the epigastric region, left lobe of liver, aortic pulsations or right ventricular hypertrophy. Then backside, infrascapular and interscapular, if any intercostal artery pulsations is there, that indicates coarctation of aorta, Sussman sign. And any kyphosis, scoliosis, scars and sinuses is there, you will see it. This is about inspection. Next, move on to the palpation. For palpation, students, you will use your hand, right hand. The tip of the fingers is used to feel the impulse and localize it. The tip of the fingers to feel the impulse and localize it. where the base of the fingers is used to feel for the thrills, where the base of the hand is used to look for any heaves, parasternal heaves. So what are the things you look in palpation? First is again apical impulse. Apical impulse is the lowermost and outermost impulse, prominent impulse present. Normally it is situated just 1 centimeter medial to the mid-clavicular line. Let us see in him where is the apical impulse is situated. So first you have to feel with the hand like this for the apical impulse, and then you have to localize it. I am feeling here. So this is the angle of Louis. Below the angle of Louis is the second space, third space, fourth space, fifth space. So it is in the fifth space, just medial to the clavicular line, mid-clavicular line. Which are the conditions apical impulse is not visible? If it is behind a rib, dextrocardia, obesity, pericardial effusion, pleural effusion, COPD or emphysema, you may not be able to feel the apical impulse. Then after feeling the apical impulse, you have to characterize it. What character is the apical impulse? The tapping apical impulse you get in mitral stenosis. It just comes, touches your finger and then it goes back. Tapping apical impulse in a mitral stenosis. Then there are two important types of apical impulse, hyperdynamic and heaving. Hyperdynamic apical impulse you get in volume overload like mitral regurgitation, aortic regurgitation. Whereas heaving apical impulse you get in aortic stenosis, hypertension, HOCM. In both heaving apical impulse and hyperdynamic, the amplitude will be increased, but the duration is more than 2/3 of the systole in heaving, whereas between 1/3 and 2/3 in hyperdynamic. Hyperdynamic is also known as ill-sustained heave. Heaving is also known as sustained heave. Hyperdynamic impulse usually occupies more than 2 spaces, whereas heaving usually will be localized to 1 intercostal space. Then what are the other types of apical impulse? You may get double apical impulse 2 times in ventricular aneurysm, LVBB, HOCM. Triple or quadruple apical impulse you may get in HOCM sometimes. Retractile apical impulse you get in constrictive pericarditis, it retracts. These are the apical impulse characteristics. So LVBB, left ventricular aneurysm, then HOCM you may get double apical impulse, triple or quadruple in HOCM, retractile in constrictive pericarditis, tapping in mitral stenosis, and hyperdynamic and heaving. Hyperdynamic you get in volume overload, aortic regurgitation, mitral regurgitation. Whereas heaving you get in pressure, aortic stenosis, systemic hypertension, HOCM, where there is a pressure overload to the LV. First, so this is a palpation apical impulse. Next is the palpation of parasternal heave. How do you look for the parasternal heave palpation? Ask the patient to hold breath in expiration. Put your ulnar border of the hand over the left parasternal. सांस है ना, सांस लेकर बाहर छोड़कर उसी तरह होल्ड करना, उसी तरह बाहर छोड़ो, उसी तरह रहो. You have to put your ulnar border of the hand over the left parasternal area. This is how you look for parasternal heave. There is a Ames grading of parasternal heave. where parasternal heave is just visible, not palpable. Grade 1. Grade 2 is visible, palpable, but obliterable. Grade 3 is visible, palpable, cannot be obliterated. What are the cause of left parasternal heave? It can occur due to right ventricular hypertrophy or left atrial enlargement. Right ventricular hypertrophy can occur either due to a pressure or volume overload. The right ventricular volume overload occurs in ASD and VSD due to left to right shunt. Whereas the right ventricular pressure overload occurs in pulmonary stenosis. Left atrial enlargement will occur in mitral regurgitation and mitral stenosis. Either the blood will go back to left atria or there will be stenosis of the valve, left atria will get enlarged. In these conditions, you get parasternal heave. Then the third thing in palpation is shocks. Shocks are nothing but palpable sounds. Some sounds you may palpate, that is shocks. Which are the sounds which you can palpate? The S2, the A2 and P2 components, sometimes you may palpate, able to palpate, palpable P2, palpable A2. In which condition you will be able to palpable P2 and palpable A2? When there is hypertension. P2 palpable in pulmonary hypertension, A2 palpable in aortic systemic hypertension. Click in a valvular pulmonary stenosis or a valvular aortic stenosis, you may get an ejection click which is palpable. In mitral stenosis, you may get a palpable S1, that is tapping apical impulse, or opening snap, you may be able to palpate it. S3 and S4, sometimes you may palpate. In S3 in dilated cardiomyopathy, S4 in HOCM, you may be able to palpate it. So I repeat, shocks are the palpable sounds. A2 and P2, you will get in systemic hypertension and pulmonary hypertension, you may be able to palpate the sound. Click. Ejection click, aortic ejection click, pulmonary ejection click you may get because of valvular stenosis. Opening snap and S1 you may palpate in mitral stenosis. S3 in dilated cardiomyopathy, S4 in HOCM you may be able to palpate it. So after apical impulse, parasternal heave, shocks, then thrill. What are thrills? Thrills are nothing but palpable murmurs. What is the importance of thrill in cardiovascular system examination? If thrill is there, it is organic murmur, not functional. That is number one. If thrill is there, it localizes the lesion. For example, if the thrill is in mitral area, then the lesion is in mitral valve. If it is at the base, aortic area, the lesion is at the aortic valve. It localizes. Then thrill indicates grade of the murmur. If thrill is there, it is grade 4 murmur. By and large, the thrills at the mitral area are diastolic. At the base of the heart, it is systolic. But in severe MR mitral regurgitation, you may get a systolic thrill in mitral area, or severe AR, you may get diastolic thrill in a base. But in general, mitral area thrills are diastolic. The base of the heart thrills are systolic. Which are all the areas you look for thrills? I told yesterday how to palpate for the carotid. While palpating for the carotid, you may get a thrill, that is carotid shudder. In aortic stenosis, you get. You may get a thrill in a left first intercostal space, that is also known as Gibson space, that is in PDA, patent ductus arteriosus, left first intercostal space, PDA. If you get a thrill in pulmonary area, that is due to pulmonary stenosis, or in 30% of the ASD, you may get a thrill in pulmonary area. If you get a thrill in aortic area, that is aortic stenosis, or severe AR, you may get a diastolic thrill in aortic area. Thrill in the left third fourth intercostal space just lateral to the sternum indicates ventricular septal defect, VSD. lateral to the sternum, third, fourth intercostal space. In mitral area, thrill indicates mitral stenosis, but you may get a systolic thrill in mitral regurgitation. So, mitral stenosis thrill is a diastolic thrill. You may get a systolic thrill in mitral regurgitation if it is very severe. So, dear students, thrill is a palpable murmur. It indicates organic grading of the murmur and localizes it. By and large, mitral area thrills are diastolic. The base of the heart thrills are systolic, but exceptions are there. Which are the sites to look for the thrill? Carotid, Gibson area, aortic area, pulmonary area, left, third, fourth intercostal space, left just lateral to the sternum and mitral area. So these are the things which you look in palpation. Apical impulse, parasternal heave, shocks, thrills. Next we'll go to the percussion. One condition where you should not do percussion is if patient is in atrial fibrillation, you should not do percussion because it may dislodge the thrombus and it may throw the embolism. The three borders which are important, especially two borders which are very important is the right heart border and the base of the heart percussion. Now I will demonstrate how to percuss the right heart border. So you come from the second intercostal space till down the lever dullness, resonant, third space, fourth space. See, this is dull. You can make out the difference. This is dull. So lever dullness is in the fifth intercostal space. Now you have to go one space above and then percuss lateral to the sternal border. So one space above I will percuss lateral to the sternal border. So it should correspond to the right sternal border. The cardiac dullness should correspond to the right sternal border. Suppose if the cardiac dullness is away, if it gets here, away from the right sternal border, which are the conditions? Pericardial effusion, fluid in the pericardium, or aneurysm of the ascending aorta. Next, how do you percuss the base of the heart? The base of the heart, dear students, you should percuss superficially. It is called superficial cardiac dullness. You should not percuss deep because there is lung resonance, you will get it. If you percuss deeply, it's just superficially you have to percuss. The normal cardiac dullness is present in the left third intercostal space. Suppose if you get dullness in the left second or first, again that indicates pericardial effusion or pulmonary hypertension. So I will show how to percuss the base of the heart. Percussion first space here, light percussion. See, it is dull here. Third space, it is dull here. If it is dull in second space, then that indicates pericardial effusion or pulmonary hypertension. This is the base of the heart. Now, how do you percuss the left heart border? Not that much important, but still you should know. First, palpate the apical impulse. Now, here it is the apical impulse. Then, in the same space, go to the mid-axillary line. Then, start percussing parallelly to the heart border. It should correspond to the apical impulse, the dullness. Suppose if it is not corresponding, then again indicates pericardial effusion. So, palpate the apical impulse. In the same space, go to mid-axillary line. Then percuss parallelly towards the heart. Okay. This is the percussion of the heart. Now, next coming to the auscultation. Which are all the areas you will auscultate and which are all high pitch sounds and low pitch sounds? The areas you auscultate is a mitral area. Mitral area is the left fifth intercostal space 1 cm medial to mid clavicular line. Tricuspid area, lower left sternal border is a tricuspid area. This is a tricuspid area. This is a mitral area. then aortic and pulmonary area. Right second intercostal space is aortic area, left second intercostal space is pulmonary area. There are other areas you can auscultate. Gibson area, left first intercostal space, Gibson space, and left third intercostal space, neo-aortic area, neo-aortic area. So mitral, tricuspid, aortic area, pulmonary area, Gibson space, left first intercostal space, Gibson space, and neo-aortic area, left third intercostal space. What are the low pitch sounds you will auscultate in cardiovascular system examination? Low pitch sounds which you will auscultate are mid-diastolic murmur of mitral stenosis, S3 and S4. Which are the high pitch sounds with the diaphragm? Low pitch sounds you have to auscultate with the bell, high pitch sounds with the diaphragm. You will auscultate the systolic murmurs, the early diastolic murmur, opening snap, clicks, pericardial knock, pericardial rub, then prosthetic valve sounds. If I repeat, low pitch sounds are mid-diastolic murmur, S3 and S4. High pitch sounds are systolic murmurs, early diastolic murmur, opening snap, clicks, pericardial knock, pericardial rub, prosthetic heart valve sounds. Now first let us go to the heart sounds. S1 will go. Why S1 is produced in cardiac, in heart? S1 is produced due to the closure of the AV valves. Closure of the atrioventricular valves. S1. It has two components. Mitral valve closure is M1, tricuspid valve closure is T1. Which are all the conditions you get loud S1? If there is a tachycardia, short PR interval, an important cardiovascular lesion, valve lesion which produces loud S1 is mitral stenosis, tricuspid stenosis. One congenital anomaly which produces loud S1 is Epstein's anomaly due to a thick anterior tricuspid leaflet wall. The T1 component will be loud in Epstein's anomaly. Which are the conditions S1 will be soft? S1 will be soft in mitral regurgitation, tricuspid regurgitation, and in MS and TS, if the valve gets calcified, you get a soft S1 and prolonged PR interval. Where you get variable S1? Atrial fibrillation, VPSS, complete heart block, you get a variable S1. So dear students, I repeat, S1 is produced by the closure of the atrioventricular valve. There's two components, M1 and T1. M1 occurs early, T1 occurs later. Loud S1 is produced by mitral stenosis, tricuspid stenosis, and short PR interval. Why you get loud S1 in mitral stenosis? Because there's a pressure gradient. LA pressure is more. The AV valves are moved very far into the ventricle. So when the ventricle contracts, there is a wide excursion. For example, if a door is widely open, if you close, you will get a sound, loud S1. That is a mechanism why you get a loud S1 in mitral stenosis. Soft S1 you get in mitral regurgitation, tricuspid regurgitation, calcified mitral valve and calcified tricuspid valve and prolonged PR interval. Now next coming to the S2. Why S2 is produced? S2 is produced due to closure of the semilunar valves, aortic and pulmonary semilunar valves. S2 is produced due to that. And it has two components, aortic component and pulmonary component, A2 and P2. Usually A2 and P2 are separated by 30 milliseconds. Which are the condition you get loud S2? Loud A2 in systemic hypertension and syphilitic AR, tambur like A2 you may get. Loud P2 in pulmonary hypertension. Loud A2 in systemic hypertension, loud P2 in pulmonary hypertension. Where you get soft S2. Corresponding valvular stenosis, aortic stenosis A2 will be muffled, pulmonary stenosis P2 will be muffled. Then as I told, A2 occurs early, P2 occurs late. If A2 occurs still early, the splitting is widened, or if P2 occurs late, splitting is widened. So A2 occurring very early or P2 occurring very late, splitting will be widened. Which are the conditions? Now A2 should occur very early. Which conditions? Less blood in the left ventricle, for example VSD, mitral regurgitation. Less blood, A valve will close early, seminal valve will close early, aortic seminal. You get early A2. Or ventricle is contracting early, for example VPC arising from the LV, or if the pacemaker has been put in the LV, early A2 will occur. P2 late, if pulmonary stenosis, so much time taken for the blood to eject into the pulmonary artery and then the valve closes, pulmonary valve. So pulmonary stenosis or RBBB, you get a late P2. So split is widened. Wide fixed split is a feature of atrial septal defect. Wide is wide because pulmonary hangout interval is increased, it is widened, and it is fixed because both during inspiration and expiration the LA and RA pressure will be equal. It can't vary with respiration. That is why it is fixed. Normally with inspiration the S2 split will widen normally with inspiration because blood will enter the right ventricle, pulmonary valve will close lately. That is why P2 will be little, it widens with inspiration normally. But in ASD, throughout the respiration, inspiration or expiration, the pressure will be equal between right side and left side. So it cannot widen. It cannot change. It is fixed. It will widen, but it is fixed. It's a wide and fixed split is a feature of ASD, partial anomalous pulmonary venous connection. In a ASD, this split can be variable if there is a associated AF or sinus venosus ASD. Now, where you get reverse splitting? Reverse splitting, P2 should occur early or A2 should occur late. When A2 will occur late, LVBB or aortic stenosis, or P2 should occur early. When P2 will occur early, if there is a VPC arising from the RV or if RV pacemaker is there, P2 will occur early. Reverse splitting. Single S2 you may get in pulmonary atresia or aortic atresia, single S2, or in phallus tetralogy due to because of the pulmonary stenosis, truncus arteriosus, transposition of great vessels because of pulmonary stenosis, you may get a single S2. And in truncus arteriosus there is only one vessel which divides into pulmonary and aortic, so you may get a single S2. So this is about S2. Now coming to the S3. Why S3 is produced? S3 is produced due to the passive ventricular filling during diastole. S3 is produced. S3 can be a normal in athlete, children, younger people less than 40 years of age groups. Pathological S3 you get in ischemic heart disease, high output states, VSD, PDA, MR, AR and TR, right sided S3. LVS3 may be physiological or pathological, but RVS3 is always pathological. S3 you will auscultate with the bell as a stethoscope. Then S4. Why S4 is produced? S4 is produced due to the atrial contraction. Atria should contract against a stiff ventricle. Which conditions? Aortic stenosis, systemic hypertension, HOCM. Atria has to contract against a stiff ventricle, or there may be a diastolic dysfunction due to ischemic heart disease. So these are the conditions where S4 is produced. Triple rhythm, S1, S2, S3 you may get. That is called atrial triple rhythm, or S1, S2, sorry, the ventricular triple rhythm. S1, S2, S4 you may get because of atrial contraction, that is triple atrial rhythm. If all S1, S2, S3, S4 you get a gallop like a horse, how it rides, at that time you get a sound, a gallop rhythm you may get. This is about S1, S2, S3 and S4. Next is opening snap. Opening snap, it's a high pitched sound. You will auscultate with the diaphragm. The place where you will auscultate for the opening snap is either in between the mitral area and the sternum, or just medial to the apical impulse you can auscultate, or sometimes it may be heard all over the precordium. Opening snap. Opening snap is produced in mitral stenosis due to the opening of the AV valves. If valves are calcified, then you won't get the opening snap. The normal 2 opening snap gap is 40 to 120 milliseconds. Then clicks. In a valvular AS, valvular PS, you will get ejection click at that site only. Aortic valvular AS, you will get click in aortic area. Pulmonary valvular AS, you will get ejection click in a pulmonary area. Pulmonary ejection click sound is the only sound which will decrease with inspiration, increase with expiration. All right-sided sound will increase with inspiration. All left-sided sounds will increase with expiration. But this pulmonary ejection click is the only sound which decreases with inspiration, increases with expiration. Why? With inspiration, the more blood enters the right ventricle, valve will be pushed up. So when ventricle contracts, only little it can move. That's why the click won't be that much. That's why that sound decreases with inspiration. Pulmonary ejection sound or a click. Mid-systolic click you get in mitral valve prolapse and tricuspid valve prolapse. Mid-systolic click and late systolic murmur in MVP and tricuspid valve prolapse. That is about clicks. Then diastolic knock. Constricted pericarditis, initially there will be a brisk relaxation. Later it will be hampered by the calcified pericardium. That brisk relaxation will suck the blood from atria to the ventricle during the diastole. That is called as a diastolic knock. You may feel, which I discussed in JVP, Frederick's sign, the rapid white descent in JVP, Frederick's sign. It is a pericardial knock you can auscultate and get it. Then pericardial rub, which I discussed in chest pain. Pericardial pain will be radiating to the neck and the shoulder. Patient prefers to sit and lean forward. Which are the sites you look for a pericardial rub? The pericardial rub will be auscultated in the left, third and fourth intercostal space. Left, third and fourth intercostal space just lateral to the sternum. That is the place where you will auscultate for a pericardial rub. Then tumor plop, left atrial thrombus or left atrial myxoma. During diastole, it may come and obstruct. You may get a sound, that is tumor plop, diastolic sound. Then you may get prostatic valve sounds. If aortic and mitral valve is there, prostatic sounds you may get. So this is about the heart sounds: S1, S2, S3, S4, opening snap, clicks, diastolic knock, pericardial rub, tumor plop, then prostatic sounds. The two things which I should have told in palpation is, one is palpable P2. If you can palpate in left second intercostal space in the pulmonary area, that indicates pulmonary hypertension, palpable P2. And in epigastric pulsations, I told because of 3 conditions: one, left lobe of liver, RV or aorta. How do you distinguish? You put your thumb in the epigastric region like this. Put your thumb. If the impulse comes and touches the left side of the thumb, it is left lobe of liver. If it touches tip of the thumb, it is RV. If it touches the pulp, it is aorta. Students, now let us go to the discussion of cardiac murmurs. Hello students, now let us go to the examination of the cardiac murmurs. Under what headings cardiac murmur should be described and examined? First, where is the site you are hearing the murmur? Mitral area, aortic, tricuspid, that area you have to specify. Then whether it is systolic or diastolic, you have to time with the carotids, okay? If it comes along with the carotids, it is systolic murmur. Then high pitched or low pitched. So all low pitched murmurs you have to hear with the bell of the stethoscope, like a mid diastolic murmur. Then whether it increases with inspiration or expiration. All right side murmur will increase with inspiration, all left side murmur will increase with expiration. Then what is the grade of the murmur? How do you grade murmurs? If thrill is there, if palpable murmur thrill is there, it is grade 4. There are total 6 grades of murmurs. But the diastolic murmurs are graded only till 4. So grade of the murmur. Then any conduction or radiation is there, you have to look. AS murmur will conduct to the carotids. The MR murmur may conduct to the axilla or base of the heart. Then which position is better heard? For example, MD murmur is heard in the left lateral position. Aortic regurgitation murmur is best heard with the bending forward, breath held in expiration. Then dynamic auscultation. So under these headings, you will describe a murmur and you will auscultate. Now first let us come to the systolic murmurs. Which are the systolic murmurs? Early systolic, mid systolic, late systolic. Early systolic you get in a very small VSD. Why you get in a very small VSD is ventricular septal defect is very small, and when the LV contract, that small hole will get closed in later part of systole. That's why you get only early systolic murmur in a very small VSD, malady rogeri. Malady Roger, very small VSD, early systolic murmur. Or VSD with a pulmonary hypertension, also you may get an early systolic murmur. And acute MR and acute TR also you may get early systolic murmur. That is acute TR without pulmonary hypertension, you will get an early systolic murmur. Then mid systolic murmur. Mid systolic murmur, you get in pulmonary stenosis and aortic stenosis. It is a crescendo decrescendo murmur and corresponding sounds will be muffled. In aortic stenosis, A2 will be muffled, pulmonary stenosis, P2 will be muffled. Students, I have given an audio clip from the Littman library of one with the AS and AR and another is a pulmonary stenosis murmur. All of you go and auscultate. If you have any doubt, Littman library you can keep on auscultating till you become familiar with the murmur. I have given the audio clip in my module, you can auscultate that. So early systolic, mid systolic, next is late systolic. Late systolic murmur you get in mitral valve prolapse and tricuspid valve prolapse. That is, you get a click, mid systolic click and a late systolic murmur. Both in MEP and tricuspid valve prolapse, you get a late systolic murmur. Then you have pansystolic murmur. Throughout the systole, between S1 and S2, the murmur will be heard. There are 3 conditions where you get a pansystolic murmur: mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Mitral regurgitation you will hear in the mitral area. Tricuspid regurgitation murmur you will hear in the tricuspid area. VSD murmur in the left, third, fourth intercostal space lateral to the sternum. I give an audio clip of VSD murmur. You can auscultate, students, a pansystolic murmur, which will be same even in TR and MR. So these are the systolic murmurs. Next is diastolic murmurs. early diastole and mid diastole. Early diastolic murmur you get in pulmonary regurgitation and aortic regurgitation. Pulmonary regurgitation in pulmonary hypertension, that is Gram-Steele's murmur. Aortic regurgitation murmur you will hear in a neo-aortic area with the patient sitting, breath held in expiration. So patient should be sit, bend forward. जब मैं बोलता हूँ सांस लेकर सांस छोड़कर उसी तरह होल्ड करना, ठीक है, इस तरह. Okay. So students, the neo-aortic area, left third intercostal space, then with the diaphragm, ask the patient to bend forward, सांस ले, सांस छोड़ो, रखो, उसी तरह रखो, ना उसी तरह रखो, सांस छोड़ो, उसी तरह रखो. Or you can ask the patient to grip the hand. जब मैं बोलता हूँ हैंड को टाइट से होल्ड करना, सांस ले, सांस छोड़ो, स्टॉप, हैंड टाइट. Okay. Dear students, so you saw how to auscultate for aortic regurgitation murmur. So early diastolic murmur, pulmonary regurgitation, aortic regurgitation. Next is mid diastolic murmur. Where you get mid diastolic murmur? You get in mitral stenosis and tricuspid stenosis. The auscultatory cycle in mitral stenosis is there will be S2 opening snap, that is 2 opening snap gap will be there. Then you will get MDM, then presystolic accentuation. So S2 opening snap, the duration indicates the severity. If it is shorter, the more severe. If it is longer, less severe. Same you get MDM in tricuspid stenosis. I have one audio clip of mitral stenosis students, just auscultate. It is a rough and rumbling murmur. How do you auscultate for MS murmur? It's a localized murmur in the 5th intercostal space with a bell you make left lateral. The bell of the stethoscope, उस तरह make him left lateral. Okay, right. That is how you auscultate for a mitral stenosis murmur. There are other MDM murmurs, Caricum's murmur. In rheumatic fever, mitral valvulitis, you get a mid-diastolic murmur, Caricum's murmur. Austin Flynn murmur, in aortic regurgitation, the blood flow from the aorta will rumble over the anterior mitral leaflet wall, producing a mid-diastolic murmur, Austin Flynn murmur. Then Riton's murmur in a complete heart block is a mid-diastolic murmur. Then there are flow murmurs, mid-diastolic murmurs, like in VSD, PDA, MR, AR, you may get a flow MDM murmur. So this is about systolic murmurs and diastolic murmurs. Next is continuous murmurs. Continuous murmurs by definition will come in the systole, engulf the S2 and then they go to the diastole. They need not be in the full duration, systole and diastole. Even if a part of systole, a part of diastole is okay, but they should engulf S2, then only it is called continuous murmurs. Which are the condition you get continuous murmurs? From systemic to pulmonary connection like PDA, aortopulmonary window, tricuspid atresia, pulmonary atresia due to the collaterals. Anomalous left coronary artery from pulmonary artery, or a connection between the systemic circulation and the RA or RV, rupture of sinus of valsalva, coronary AV fistula, systemic AV fistulas, or there may be a flow through a stenosed arteries. For example, renal artery stenosis, coarctation of the aorta, peripheral pulmonary artery stenosis, or there may be a high flow through a normal vessel, uterine shuffle, mammary shuffle, a venous hum, cervical venous hum, curvular Baumgarten syndrome, where you are getting cirrhosis, hepatoma, renal cell carcinomas, you may get a continuous murmurs. Next is to and fro murmurs. To and fro murmurs, in a single channel the murmur will occur, that is for example AS and AR, without engulfing the P2. Next is systolo-diastolic murmurs. Systolo-diastolic murmurs will occur in different channels. For example, VSD and AR. VS is a pansystolic murmur, AR is a diastolic murmur, without engulfing the S2. Systolo and diastolic murmurs. Then changing murmurs. The murmur will change in the intensity. Caricamus murmur, the murmur will change in the intensity. Atrial myxoma, if you stand, the tumor will block, so murmur will change. Infective endocarditis, the murmur will change. Then innocent murmurs. Innocent murmurs occurs in a normal heart due to the high blood flow. Still's murmur in a child is innocent murmur. 50-50 murmur. Any person who is more than 50 years, they can have a systolic murmur in 50% of the cases. Then there can be functional murmurs due to the high flow or dilated chambers. For example, functional MDM, as I told you, get in VSD, PDA, MR, AR, left-sided MDM you may get. Right-sided MDM you get in ASDs, tricuspid regurgitations. So, functional murmurs. Now, which are the named murmurs? Gram-Still murmur of pulmonary regurgitation is a named murmur. Gibson left first intercostal space continuous murmur, what you get in PDA is a named murmur, Gibson murmur. Caricamus murmur in a mitral valvulitis in rheumatic fever. Ostenfeld murmur in aortic regurgitation is a named murmur. Sisson-Coley murmur in aortic regurgitation you may get in axilla, early diastolic murmur, that is Sisson-Coley murmur. Then Gilliwarden phenomena. Gilliwarden phenomena is aortic stenosis murmur sometimes better heard in a mitral area due to the conduction of the high frequency sound to the mitral area. The ESM, the ejection systolic murmur in aortic stenosis, is better heard in a mitral area due to the conduction of the high frequency sound. This is known as Gilliwarden phenomenon. These are the named murmurs. Now, the dynamic auscultation. What are the things you see in dynamic auscultation? Already I have told one dynamic auscultation. All right side murmur will increase with inspiration. All left side murmur will increase with expiration. Then Valsalva maneuver. Valsalva maneuver is nothing but an expiration. In a Valsalva maneuver, usually all the murmurs will reduce except two murmurs, that is HOCM and MVP, will increase in intensity. See, one thing you remember, in HOCM and MVP, anything which reduces the blood supply to the LV will increase the murmur. So, in a Valsalva maneuver, there is less blood to the LV, so the murmur will increase in MEP and HOCM. Because if LV size is less, valves can prolapse more. Then, after Valsalva maneuver, exercise. You have two exercises, isotonic and isometric exercise. Isotonic is running Isometric is hand grip, lifting weight. Isotonic and isometric exercise will increase the murmur in all stenotic murmurs. Both isotonic and isometric exercise will increase the murmur in stenotic murmurs, aortic stenosis, mitral stenosis. Whereas only isometric exercise increases the murmur intensity in regurgitation lesions, MR and AR. Whereas isotonic exercise will reduce the murmur in MR and AR. Why? Isotonic exercise, the peripheral vascular resistance will reduce. When the peripheral vascular resistance is reduced, the regurgitation occurs less to the LVI because the blood can go to the aorta from the LV in a mitral regurgitation. So that is exercise. Then positional change and postural change. Ask the patient to make stand. All the murmur when standing will reduce, except as I told, if anything LV blood supply reduces, MVP and HOCM will increase. When standing, blood will be less to LV. So MVP and HOCM murmur increases on standing. The opposite occurs with the leg raising. More blood enters the LV, so all the murmurs will reduce, but all the murmur will increase except HOCM and MEP because more blood enters the LV when the passive leg raising. Hand grip and squatting. All the murmurs will increase except HOCM and MEP, which will reduce. So anything which increases the peripheral resistance will reduce the MEP and HOCM murmur. Anything which reduces the LV cavity size will increase the murmur of HOCM and MEP. So standing, passive leg raising and squatting. Passive leg raising and squatting have the same effect. Then after a VPC, post extrasystolic contraction, or after atrial fibrillation, what happens? After a post extrasystolic contraction or atrial fibrillation, the stenotic murmur will increase in intensity, AS and MS. Whereas the regurgitation lesions, MR and AR, will reduce in intensity in a post extrasystolic contraction and in AF after the long RR interval. Then what happens with the drugs, amyl nitrate? Amyl nitrate is a potent vasodilator. If you inhale the amyl nitrate, stenotic murmurs will increase, AS and MS. The regurgitation lesions will reduce because peripheral vasodilatation. As I told in isotonic exercise, there is peripheral vasodilatation. Whenever there is a peripheral arterial dilatation, the blood can enter the aorta rather than going back to the LA. So MR and AR murmur will reduce, whereas the stenotic murmur will increase with amyl nitrate. So dear students, if you know the mechanism, it is easy to remember the dynamic auscultation. So this is about dynamic auscultation. So we finish the cardiovascular system examination with this. Dear students, go to Lippmann library, you have a very good sounds, try to listen to it. And if you get patients in your hospital, also try to listen to it. I have given 4 clips. And I have covered the basic symptoms, examination of the cardiovascular system. And I have taken from Harrison's, Braunwald and clinical method books. Thank you, students. Hello, namaste students. Till now we have discussed cardiovascular system, the symptomatology, general physical examination, and then the pulse, blood pressure and JVP recording. And also we have discussed examination, proper inspection, palpation, percussion, and in auscultation about the heart sounds, opening snap, clicks, then the pericardial knock, the added sounds because of the prosthetic valves, okay, and lastly the murmurs. So I want to tell little briefly about the murmurs before discussing practically about where to auscultate and what are the characteristics of the murmur. Dear students, see in the A, this is the first heart sound, this is the second heart sound. So between first to second heart sound is a systole, and then from second heart sound to again first heart sound is a diastole. These are normal. You can just see there are no any murmurs in the systole or diastole. This is a normal one. Second one is the aortic stenosis. Dear students, here you can see in the systole there is a crescendo decrescendo murmur. Okay, the crescendo decrescendo murmur, the diamond shaped murmur. This is the ejection systolic murmur of aortic stenosis. You get same murmur in pulmonary stenosis also. Okay, the crescendo decrescendo murmur. Next, students see in mitral regurgitation. This is a systole S1 and S2. Throughout the systole, you can make out a murmur here. There is a pan-systolic murmur. Okay, throughout the systole, there is a murmur between S1 and S2. This is a pan-systolic murmur, which you also get in tricuspid regurgitation and ventricular septal defect. In the D, students, you see aortic regurgitation murmur. See, this is a diastole between S2 and S1. This is a systole S1 and S2. So in the diastole, you can see there is an early diastolic murmur. Okay, EDM, early diastolic murmur, which you get even in pulmonary regurgitation also. Early diastolic murmur. The next, students, you see in a mitral stenosis. So this is a systole S1 and S2, and between S2 and S1 this is a diastole. You can see here a murmur, the mid diastolic murmur here, and it has become little increased in intensity before the systole. This is known as a pre-systolic accentuation due to the atrial contraction. Due to the atrial contraction before the systole. Pre-systolic accentuation. And then lastly, students, you can see patent ductus arteriosus, where there is a murmur both in systole and diastole engulfing the S2. It engulfs the S2. So this is a continuous murmur. A continuous murmur is one which present both in systole and diastole engulfing the S2. It need not be present throughout the systole, but it should be both in systole and diastole, and it should engulf the S2. That is the patent ductus arteriosus, continuous murmur. So if you classify systolic murmurs, see students here, mid systolic murmur or ejection systolic murmur between S1 and S2. This is A2 and P2 of S2. Diamond shaped crescendo decrescendo murmur. A holosystolic murmur, pansystolic murmur between S1 and S2. Throughout the systole, the murmur has occupied. Students, this is seen in mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. And then here you have an early systolic murmur, students. In the early part of the systole only there is a murmur where you get in very small VSDs or a VSD with a pulmonary hypertension or acute TR or acute MR. You may get early systolic murmur. It is a short murmur. And then you have late systolic murmur, students. There is a mid systolic click here. I am saying is mid systolic click, students. So where you get the click, you get click in mitral valve prolapse or tricuspid valve prolapse. Okay. So after this click, there is a late systolic murmur. Mid systolic click and late systolic murmur is a feature of MVP, mitral valve prolapse or tricuspid valve prolapse. So these are the systolic murmurs. So what are the diastolic murmurs? In aortic regurgitation, students, this is between S2 and S1, that is a diastole. This is an early diastolic murmur here. And then in pulmonary regurgitation also you get early diastolic murmur like this. And then in mitral stenosis, students, you get mid diastolic murmur here with the pre-systolic accentuation. It has become accentuated here. Okay, pre-systolic accentuation, and this is the opening snap, the red color one. Opening snap, mid diastolic murmur, and it has accentuated. And this is a patent ductus arteriosus murmur where between S1 and S2 that is a systole, S2 and S1 that is a diastole, and it engulfs the S2. Engulf the S2. It is a continuous murmur. Patent ductus arteriosus. Students, I have given the audio clip of ventricular septal defect murmur, which is a pansystolic murmur, mitral stenosis murmur, which is a mid diastolic murmur, AS with AR, where there is both ejection systolic and early diastolic murmur, and then pulmonary stenosis, which is the ejection systolic murmur. All the 4 audio clips you can view on in the module, students.